Welcome to the deep dive. Today, we're looking at something pretty common, actually how surgical wounds heal.
That's right.
We'll explore, the normal way things go, but also what happens when there are bumps in the road, like infections or maybe wounds that just struggle to close.
And when surgeons might need to step in with reconstruction techniques.
Exactly. We're drawing insights from Wound Care Essentials, Practice Principles, specifically the chapter on surgical wounds and reconstruction. Think of this as your guide to understanding what's really going on after surgery.
Yeah, we're going beyond just the incision itself. We want to understand the biology, the actual processes happening. We'll break down the usual healing stages, talk about why complications pop up, infections, delayed healing, and look at the thinking behind surgical reconstruction.
It gives you a real appreciation for how the body fixes itself, doesn't it?
It really does, and how medicine helps that along.
Okay, let's unpack this then. When we talk about a surgical wound healing, it's not just one smooth thing, is it? It happens in phases.
Correct. 3 main phases, almost like stages in a project.
Okay.
First, you have the inflammatory phase. Then the proliferative phase, that's where new tissue gets built up.
Yelling things up.
And finally, the remodeling phase. It's quite the process happening right under the skin.
It sounds like.
And within those 3 big phases, there are actually 4 key physiological events happening.
4 events.
Yeah. First, hemostasis. That's the body immediately trying to stop any bleeding.
Step 1, stop the bleeding. Got it.
Then comes inflammation. This is crucial. It's where the body cleans up debris, fights off any early invaders, and really kicks off the healing cascade.
Okay.
Next is the repair phase proper, where the new tissue, the granulation tissue, is generated.
Building the scaffold.
Kind of, yeah. And finally, remodeling. That's where that new tissue matures, gets stronger, reorganizes itself over time. It's a very precise sequence.
And how long does all this usually take? Because, a paper cut feels like nothing, but surgery seems longer.
Well, for a typical acute surgical wound, those first 2 phases, inflammatory and proliferative, they usually take about, say, 21 to 30 days combined.
Okay, about a month.
Roughly. But the remodeling phase, that's the long haul. That can actually go on for a year, sometimes even 2 years, as that scar tissue strengthens and changes.
Wow, 2 years.
Now, it's worth remembering, a really superficial wound, like just a scrape on the very top layer of skin, the epidermis, that heals a bit differently, quicker through regeneration.
Right, that makes sense. So sticking with surgical wounds, you mentioned different ways they heal. Primary intention, secondary. Those terms.
Absolutely. So healing by primary intention is what surgeons usually aim for.
The ideal scenario.
Yes. It's when the wound edges are neatly brought together. Think sutures, staples, maybe surgical glue, like sewing 2 edges of fabric.
Okay.
Then you've got secondary intention. This is when a wound is left open to heal from the bottom up.
Let's look open. Wow.
Maybe it was contaminated or there's tissue loss. The body fills the gap with new tissue granulation, and then the skin slowly grows over it from the edges. That's called epithelialization.
Okay, slower process.
Definitely slower. And finally, there's tertiary intention. This is sort of a delayed primary closure.
Like a mix.
Kind of. The wound might be left open initially, maybe to clear up an infection or let swelling go down, and then it's surgically closed later on.
Got it. So a standard surgical incision, closed with stitches, that's primary intention.
Exactly.
And I read it's really important to protect that initial suture line.
Oh, absolutely critical, especially for the first 48 hours or so.
Why specifically then?
That's the rough time frame it takes for the body to form a natural seal, for the skin barrier to start reforming. So that primary surgical dressing, it's acting as a physical shield during that really vulnerable time, protects against bumps, keeps bacteria out.
Keeping it clean and dry is key then.
Definitely. A moist environment under that initial dressing can actually help bacteria grow, which you absolutely don't want.
And dressings themselves. We've moved beyond just basic gauze, right?
We have in many cases. Gauze and tape are still around, of course, but lots of surgeons now prefer more advanced composite dressings.
What's better about them?
Well, some even have antimicrobial agents built in. But the move away from plain gauze is partly because gauze isn't super absorbent.
Right.
And when it dries out and sticks, removing it can actually pull off some of that delicate new healing tissue.
Ouch. Painful too, I bet.
It can be, yes. Plus, some of the traditional tapes used to hold gauze on, the non-silicone ones, or even some transparent films. They can sometimes cause skin stripping or moisture damage around the wound.
Okay, so that's the ideal healing path. But inevitably, things can go wrong. Surgical site infections, SSIs, they sound like a big worry.
They are a major concern, absolutely. Preventing them is a huge focus in healthcare.
Why the big focus?
Well, it really ramped up back in 2008. That's when CMS, Medicare and Medicaid Services, said hospitals wouldn't get paid extra for treating certain conditions patients acquired in the hospital.
Financial incentive.
Exactly. And SSIs were right near the top of that list. It's a global issue. In the U.S. alone, you're looking at maybe up to 300,000 SSIs each year.
300,000, wow.
Yeah. And these aren't just costly in terms of dollars. They lead to serious complications for patients.
And I heard a lot of them show up after the patient goes home.
That's a really important point. A significant chunk are indeed detected post-discharge.
Which makes tracking and managing them harder, I suppose?
It does.
Are all SSIs the same? Or are there different types?
Good question. There are three main categories. First, superficial incisional SSIs. These just involve the skin and the tissue right underneath the subcutaneous layer.
Okay, just the surface layers.
Right. Then you have deep incisional SSIs.
Mm-hmm.
These go further down, affecting the deeper tissues like the fascia, that tough connective tissue layer, and the muscle.
Deeper. Okay.
These can be primary or secondary, depending if it's the main incision or another cut made during the op.
And the third type?
That's organ space SSIs. These affect any part of the body other than the skin, fascia, or muscle that was opened or manipulated during surgery. So, inside an organ or a body cavity?
Those sound the most serious.
They generally are, yes.
And the impact on the patient?
It can be significant. An SSI can mean a longer hospital stay, a higher chance of needing to come back to the hospital.
Readmission.
Exactly. And sadly, it contributes to more illness, more morbidity, and even increased mortality risks.
Because they're so serious, I assume there are guidelines for prevention.
Oh, absolutely. Loads of organizations, WHO, NICE in the UK, the American College of Surgeons, CDC, SHEA, they've all published best practice recommendations.
What kinds of things do they recommend? It must be a lot.
It's very comprehensive. It covers the whole journey before surgery, during, and after.
Like what? Give me some examples.
Okay, so preoperatively, things like managing blood sugar if the patient has diabetes, getting smokers to stop, using clippers instead of razors for hair removal near the site.
Right.
Intraoperatively, it's things like timing antibiotics just right before the first cut, keeping the patient's body temperature normal.
Normothermia, yeah.
Proper skin closure techniques. And postoperatively, it's clear instructions on how to care for the suture line.
So it takes a whole team effort.
Absolutely. The key thing is many SSIs are preventable if everyone follows these evidence-based guidelines consistently.
Okay, so we've covered infections. What about wounds that just stall? They don't seem infected, but they're just not healing.
Yeah, non-healing wounds are a real challenge. The causes can be sort of put into two buckets, extrinsic factors and intrinsic factors.
Extrinsic meaning outside stuff.
Exactly. Things like too much pressure on the wound area, not enough blood flow, that's ischemia smoking is a big one, poor nutrition.
Okay, and intrinsic, inside the body.
Right, things within the wound or the patient. That could be a low-grade infection, maybe a biofilm.
Biofilm, like a colony of bacteria.
Precisely. Very hard to treat sometimes. Or maybe there's too much tension pulling the wound edges apart, or problems with the arteries supplying blood to that area, arterial insufficiency.
It sounds like job number one is figuring out why it's not healing.
You've hit the nail on the head. Just treating the wound itself won't work if you don't tackle the underlying reason it stopped healing.
Right.
The basic idea is we as clinicians don't make the wound heal. The body does that.
We just help it.
We support it. Our job is to find the roadblocks, the obstacles getting in the way, and remove them.
So when a clinician sees a wound that's stuck, what questions are they asking?
They're usually thinking along four main lines. First, how did this wound happen and when?
The origin story.
That's sort of, yeah. Second, when did the healing go off track and why? What changed?
Okay.
Third, what factors right now are known to be stopping it from healing?
Current roadblocks.
Exactly. And fourth, what treatments have we already tried?
Makes sense.
And to really get the full picture for a non-healing surgical wound, you need to know why they had surgery in the first place, what exactly was done, their health before the surgery, what meds they're on now, their nutrition.
It's the whole person, not just the hole in the person.
Beautifully put. It's holistic.
Okay, so let's say a wound isn't healing by itself. What are the goals then? And how do surgeons decide the next step? I saw something about a reconstructive ladder.
Right. The main goal for any acute wound is closure. You want it closed, and you want it to restore the original form and function as much as possible.
Form and function. Both matter.
Absolutely. If you just let a wound shrink down and scar over on its own, that's contraction. It often doesn't look right, doesn't work right, and can break down again later.
And scarring is always part of it if the skin's full thickness is involved.
Some scarring is inevitable with any full-thickness injury, yes.
So the latter, what's that about?
The reconstructive ladder is basically a thinking process, a framework. It helps surgeons choose the right way to close a wound based on what's missing, how much tissue, and what kind of tissue.
Like climbing steps, start simple.
Exactly. The principle is to use the simplest method that will give you a stable closure with good form and function. You only move up the ladder to more complex stuff if the simpler options aren't enough.
Okay, so bottom rung of the ladder, simplest case.
That would be if no tissue is actually missing. Then usually primary closure is possible, just bringing the edges together. You get that little healing ridge under the skin.
What if skin is missing?
Then you might let it heal by granulation, filling in from below. Or often a skin graft is needed to speed things up and get better coverage. That could be a partial thickness or full thickness graft.
And if it's deeper, muscle, bone damage.
Now you're climbing higher on the ladder. You might need to transplant those tissues, often using flaps, to restore both the bulk and the function.
Flaps.
Okay.
They're named based on what's in them, like bone and skin.
Right. An osteocutaneous flap has bone and skin. A myocutaneous flap has muscle and skin.
You mentioned grafts and flaps. What's the key difference? I hear those terms a lot. Is it the blood supply?
That's the crucial difference. A graft is like laying down new sod. It has to get its blood supply from the ground it's placed on, the recipient site.
Okay, it needs to connect to the local plumbing.
Exactly. A flap, on the other hand, brings its own plumbing with it.
Its own blood vessels.
Yes, it can be moved from nearby tissue while staying connected to its original blood supply, a local flap, or it can be completely detached, artery, vein, everything moved to the new spot, and then the vessels are meticulously reconnected under a microscope. That's a free flap.
Microvascular anastomosis.
That's the term. Like plumbing in a new blood supply. A good example is a free radial forearm flap taking tissue, maybe even bone, from the forearm to rebuild part of the face after, say, cancer removal.
Wow, that's intricate. What about the place they take the tissue from? The donor site. Does that cause problems?
It always leaves a mark, definitely some scarring. And depending on what's taken, there might be some functional loss.
Like weakness.
Could be. Taking a split-thickness skin graft leaves a scar but usually heals well. But taking a big muscle, like the latissimus dorsi from the back for breast reconstruction, that might cause some shoulder weakness.
So there's a trade-off.
Always. It's balancing how much tissue is needed versus what function the patient might lose at the donor site and what they're willing to accept.
So the guiding principle is always start simple if you can.
Always. If a wound can heal well on its own by granulation and epithelialization in a reasonable time, great. If not, skin graft might be next for just skin loss.
And muscle flaps for deeper holes.
Right, to fill the defect.
No.
Sometimes you bring the skin over the muscle with it a musculocutaneous flap.
And moving muscle.
Mm-hmm.
You can stay attached or be completely moved.
Correct. Rotated on its existing blood supply or transferred as a free flap with microvascular surgery. And ideally, you try to replace like with like. Use tissue that matches the missing area in terms of texture, thickness, hair, etc. for the best cosmetic result.
Let's go back to those wounds without missing tissue. What are some typical examples?
Think of a clean cut, a simple traumatic laceration. If there's little or no tissue actually gone, you can often close it primarily.
After checking for deeper damage, I assume.
Oh, absolutely. You always need to check for injuries to blood vessels, nerves, tendons, glands underneath.
And how do they close it? Just stitches?
Often stitches, yes. But first, copious irrigation, washing it out really well is key. And sometimes a technique called undermining is used.
Undermining.
Gently separating the skin edges from the underlying tissue a bit. It gives them more stretch, lets them come together with less tension.
Less tension is good for scarring.
Definitely. Drains might also be put in temporarily if there's a risk of fluid collecting or if it was a bit contaminated. The goal is to make it look as normal as possible, but sometimes with bad trauma, that's tough.
You mentioned tension and scarring. That's a big deal.
Huge. Minimizing tension across the wound is really important for a better scar. Wounds over joints, for example, where there's constant movement, they tend to stretch and form wider scars.
So what helps minimize scarring?
Things like maybe scented dressings, keeping the area immobilized as much as possible, like limiting talking if you have stitches near your mouth. Using a thin layer of topical antibiotic ointment can help too. And maintaining moist wound healing throughout can speed things up and potentially lead to a better scar.
But some scarring is unavoidable.
Yes, everyone needs to understand that. Scar revision surgery isn't usually even considered until the scar is fully mature, which can take a year or more.
What about really big, extensive lacerations?
They can look scary, for sure. But the first priority is always life-saving stuff. ABCs, brain injury. Initial wound care is just cleaning out obvious dirt.
Then what?
For massive ones, they might just pack them with moist dressings at first to stop tissues drying out. Once the patient's stable, they go back for proper cleaning and closure, if possible. Sometimes it takes multiple trips to the OR for debridement, cleaning out dead tissue until only healthy tissue is left. These complex ones might need delayed closure with flaps later on.
I remember reading about a 6-hour window for contaminated wounds.
Yeah, that's a general guideline. Wounds not closed within about 6 hours are typically considered contaminated. Closing them after that point carries a higher infection risk.
Any exceptions?
Sometimes, yes. Very clean facial wounds in healthy people, especially if they're on antibiotics, might be closed later.
Okay. And penetrating abdominal wounds, stabbings, gunshots, those sound really dangerous.
They are extremely serious, huge risk from the direct damage, but also contamination leading to sepsis.
That's severe infection.
Right. And major bleeding is a big danger too. Depending on how dirty the wound is or if organs like the bowel were hit, the surgeon might not close the wound completely right away.
Leave it partially open.
Sometimes, yes, especially the outer layers. Managing an open abdomen is complex, lots of fluid loss, risk of infection, needing more surgeries to explore, but trying to preserve the abdominal wall for eventual closure, it's challenging, and protocols vary between trauma centers.
And this open abdomen situation can sometimes lead to something called abdominal compartment syndrome, ACS.
Yes, that's a critical, potentially fatal complication. It's like compartment syndrome in a limb, but inside the belly.
Pressure builds up.
Exactly. After surgery, trauma, even pancreatitis, pressure inside the abdomen can rise. Normal pressure is low. When it gets too high, maybe above 20 millimeters of mercury with organ dysfunction.
What does that pressure do?
It squeezes everything, compresses blood vessels, organs. It reduces blood flow to the gut, causing ischemia, bacterial problems.
Oh, wow.
As it gets worse, it affects the heart, the lungs, blood flow to the kidneys, even the brain. Recognizing it is crucial in sick patients.
So how does this relate to wound closure?
The key point is, if a patient has ACS, you do not try to force the abdomen closed. That makes it much worse.
So what do you do?
You need to leave it open, decompress it. Techniques like using a silo bag, a sterile plastic bag sutured to the skin edges to contain the contents, or negative pressure wound therapy, NPWT, are used.
Negative pressure, like a vacuum dressing.
Essentially, yes. NPWT has actually been a game changer for managing open abdomens. It helps pull edges together, manage fluid, and often allows for closure later without needing big mesh grafts like in the past.
What about when a closed abdominal wound comes apart later? Dehiscence.
Right, abdominal wound dehiscence, that's the separation of the wound edges. The real strength comes from the fascia and muscle layers. Sutures will it initially, then healing takes over, but sometimes it fails.
Why does it fail?
Could be technical issues with the closure suture type, placement, or more often patient factors.
Like what sort of factors?
Well, a big study found things like being over 50, male, having emergency surgery, long operations, post-op coughing, high blood pressure, steroid use, cancer, fluid in the belly, ascites, lung disease, jaundice, anemia, and importantly, wound infection.
That's a lot of risk factors.
It is, and certain combinations are even higher risk. Also, anything that puts extra strain on the wound, obesity, severe coughing or vomiting, ascites can contribute.
Are there warning signs? And what happens if it actually bursts open? Evisceration.
Often the first clue something's wrong is a sudden gush of pinkish yellow fluid, serosanguineous fluid from the wound.
Okay.
And then sometimes, bang, evisceration. The wound fully opens and internal organs, usually intestines, protrude. It's terrifying for the patient.
I can only imagine. What's the immediate response?
Keep the patient calm, give pain relief, cover the exposed organs immediately with a sterile towel soaked in sterile saline, keep them moist.
Don't push them back in.
Absolutely not. Patient needs to be NPO. Nothing by mouth. Get ready for immediate surgery. Keep them flat or only slightly elevated. Monitor vital signs closely for shock.
And surgery fixes it.
Surgery involves exploring the wound, cleaning out any dead tissue, and then reclosing the abdomen securely, usually with strong, non-absorbable sutures grabbing good bites of healthy fascia.
Does it usually heal okay after that?
Unfortunately, developing a hernia later on is pretty common after evisceration. And if a patient is too sick for another operation, the dehisced wound might be managed non-surgically with packing, binders, or NPWT, letting it heal by secondary intention, but that almost always results in a large hernia down the line.
Okay, let's shift gears to wounds requiring tissue transplantation. Burns seem like a prime example here.
They are. Burns very often need skin grafting. The surgical side involves things like escharotomy, cutting away the burn tissue, eschar excision, grafting, and later maybe scar revision.
It sounds like multiple surgeries are common.
Very common. Burn patients often need many trips to the OR, so having a dedicated team helps reduce their anxiety. Sometimes they go straight from their room to the OR, skipping the usual pre-op holding.
You mentioned escharotomy. What exactly is that?
It's a surgical cut made through the full thickness of the burned skin, the eschar.
Why do that?
Because deep burns make the skin lose its elasticity. It becomes like tough leather. When the patient gets lots of fluids during resuscitation, swelling occurs underneath this tight, unyielding layer.
Pressure builds up.
Exactly. It can build up enough to cut off blood flow in limbs, compartment syndrome, restrict breathing if it's on the chest, cause abdominal compartment syndrome, even pressure on the eyes. Escharotomy releases that pressure.
So you just cut through the burn.
Yes. The incisions are usually left open initially to allow for swelling. They might close on their own later, or they might need grafting themselves once the swelling goes down.
And the main way to cover burn wounds is skin grafting.
That's the standard, yes. Using the patient's own skin, taken from an unburned area and autograft, usually split thickness grafts, meaning just the top layers of skin.
And these rely on the wound bed for blood supply, unlike flaps.
Correct. Initially, they survived by just soaking up fluid serum from the wound bed. Then tiny new blood vessels have to grow from the wound bed up into the graft. That's called take.
Seeing it turn pink is a good sign.
That's exactly what you want to see. It means revascularization is happening.
So keeping the graft still is crucial.
Absolutely vital. It needs to stay in close contact with the wound bed for those vessels to grow in. Surgeons use fibrin glue, splints, stitches, bolsters, negative pressure therapy, whatever it takes to immobilize it.
What makes grafts fail?
Swelling, edema underneath the graft is a big one. It lifts the graft off the bed, prevents vessels growing in, so keeping the grafted area elevated is really important.
Infection, too.
Infection is another major cause. If the wound bed is infected, the graft likely won't take, so you need to make sure any infection is cleared before grafting.
What about after the burn heals? I've heard itching pruritus can be a big problem.
Oh, it's incredibly common and can be really distressing for survivors.
Why does it happen?
Skin grafts don't have sweat or oil glands, so the skin gets very dry. Heat gets trapped. Plus, the scar tissue itself isn't very elastic. It all contributes to itching.
Is there a good treatment?
Unfortunately, there's no single magic bullet. It's often trial and error, antihistamines, special lotions, TNS units for nerve stimulation, massage. More research is definitely needed.
And scar contractures, tight scars pulling across joints.
Another potential long-term issue. If a scar tightens as it matures, it can really limit movement. Sometimes procedures like Z-plasty, which rearranges the scar tissue, or more skin grafting, are needed to release the contracture.
Okay, let's circle back to non-healing surgical wounds more generally. Besides the factors we discussed, what else stops them healing?
Well, underlying health issues are huge. Poorly controlled diabetes, bad circulation, malnutrition, a weak immune system, they all put the brakes on healing.
And the definition of non-healing is?
Generally, a surgical wound that hasn't responded to standard care after about 3 or 4 weeks.
What's the first step surgically?
Often, it's debridement, cleaning out any dead or unhealthy tissue. And infection is a very frequent culprit, especially biofilms.
Those bacterial communities again?
Exactly. They hide from antibiotics and fuel chronic inflammation, which itself stops healing. Common bacteria are staph, Pseudomonas. Debridement helps break up those biofilms.
Median sternotomy wounds from heart surgery, you said they're complex.
They really are. Closing the breastbone after it's been split for heart surgery is tricky. The bone is wired together, but it still moves with every breath.
Constant movement.
Right. And infection in that area, mediastinitis, is a very serious complication.
Who's at higher risk?
Patients who are obese, have diabetes, heart failure, prior heart attack, emergency surgery, high blood pressure, maybe large breasts. These increase the risk. Also, long time on bypass during surgery.
What are the signs of infection there?
Redness, maybe pus draining, the wound edges separating. If it goes deep, it can involve the sternum, the space behind it, mediastinum, even grafts or devices used in the heart surgery.
How are they managed?
It depends. Might involve packing, surgical debridement. Negative pressure wound therapy is used a lot now, sometimes as the first step. It helps stabilize the chest wall, manage drainage. Studies suggest it might lead to shorter hospital stays compared to standard dressings.
Any special precautions with these deep chest wounds?
Definitely. If you're packing them, use one continuous roll of gauze if possible so you don't accidentally leave a piece behind.
Good point.
If foam is used, count the pieces meticulously. Also, be careful with topical solutions. These large wounds absorb things easily. Povidone iodine, for example, has caused iodine toxicity when used in big sternal wounds.
Wow.
And if the wound is close to the heart, packing has to be done very gently between heartbeats so you don't restrict the heart's filling. Tight packing is a no-no.
What if there are big defects in the chest wall itself, from tumor removal, maybe?
Yeah.
Chest wall reconstruction can be anything from simple closure to major surgery to stabilize the ribs and sternum.
Why is stabilization so important?
If the chest wall isn't stable, you can get paradoxical breathing where the chest wall sucks in when you breathe in instead of expanding. It severely messes up breathing mechanics.
So before reconstruction.
You need to optimize everything: heart, lungs, nutrition, get the wound bed clean. Small defects might be closed with local skin flaps. Bigger ones, especially missing ribs or sternum, often need muscle flaps like the latissimus from the back or pectoralis from the chest for coverage and stability.
Using bone or synthetic materials.
Sometimes needed for very large defects, but things like mesh or acrylics carry risks of infection or rejection.
And monitoring the flaps afterwards.
Absolutely critical. Watch for blood supply issues. Pale, dusky, cool tissue means trouble. Needs immediate attention from the surgeon.
Pressure injuries, bed sores, they can also need complex surgery, right?
Absolutely. Repairing a pressure injury surgically isn't just about the operation. It starts way before. The wound bed needs to be clean, obviously. But you have to consider the whole patient. Are there other health problems managed? What are their goals? For some, maybe very frail patients, non-surgical management might actually be better. Good nutrition, pressure relief, local care, maybe NPWT or bioengineered tissues.
But if surgery is the plan,
Then optimizing nutrition and controlling medical conditions is paramount.
nutrition keeps coming up.
It's fundamental for healing. Enough protein, calories, vitamins, minerals, sometimes calorie counts or even indirect calorimetry are needed to check intake.
What about lab tests like albumin?
We used to rely on albumin and prealbumin, but now we know they're heavily affected by inflammation, so they aren't perfect markers of nutritional status alone. For kidney patients on dialysis, though, a low prealbumin might still signal malnutrition.
And if they can't eat enough?
Tube feeding might be a temporary option to boost them up before surgery.
And for pressure injuries? Pressure relief is key, obviously.
Non-negotiable, before and after surgery. Proper wheelchair cushion, offloading devices, teaching the patient techniques. And you have to address all contributing factors: shear, friction, moisture, to prevent it coming back.
Social support matters too.
Hugely important, especially for someone with a spinal cord injury, to help maintain that healed wound long term.
Other factors before surgery: bone infection.
Spasms.
Yes. Need to rule out underlying osteomyelitis and deep ulcers. Treat other infections like UTIs. Muscle spasms can pull on wounds and hinder healing, so they might need medication like baclofen or even Botox.
Yeah.
Contractures joint stiffness make positioning hard, so range of motion exercises are important.
Debridement, cleaning out dead tissue, sounds essential for pressure injuries too.
It is. It reduces bacteria, reduces sepsis risk, and often reveals the true depth of the injury, which can be surprisingly large.
Any exceptions?
The main one is stable, dry gangrene on an ischemic limb, like a foot with poor blood flow. Debriding that can turn a contained problem into a much bigger, open, non-healing wound, so those are often left alone unless they get infected or wet. Different ways to debride.
Sure, surgical debridement in the OR is common. Sharp debridement can sometimes be done at the bedside. Enzymatic debridement uses ointments to dissolve dead tissue, good for patients who can't have surgery.
What about hard black Escher on a heel? Debride or leave it?
That's a bit controversial. Some evidence suggests leaving stable heel Escher alone might allow healing underneath. But if it gets soft, boggy, drains, or the area around it gets red, then it needs to come off to prevent deeper infection.
And when tissue is missing in a pressure injury, flaps are the go-to.
Often, yes, depending on what's missing. Skin loss over the sacrum might be closed with a skin flap or a fasciocutaneous flap. Deeper wounds with muscle loss might need a muscle flap, like from the gluteus muscle.
Does the muscle work after being moved?
No, the muscle flap doesn't provide function, but it brings padding and, crucially, a really good blood supply to help fight infection and heal the overlying tissues. Sometimes the skin comes with the muscle, a musculocutaneous flap.
And flap survival depends on that blood flow.
Absolutely. Good artery inflow, good vein outflow. Monitoring for signs of compromised paleness, coolness, slow capillary refill is vital. Flap failure is a major setback.
Post-op care for flaps.
Strict pressure relief is number one. Maybe specialized beds. Sutures often stay in longer. For wounds near the perineum, sometimes even a temporary colostomy is needed to keep stool away, and patient compliance with offloading after surgery is absolutely essential.
What about reconstruction on the leg? Big tissue loss there.
Leg defects can be closed with muscle flaps plus skin grafts, myocutaneous flaps, or free flaps. The goal is always limb salvage if possible. Big soft tissue injuries there are high risk for infection. Often needs or are debridement first. Common flaps include muscles like the gastrocnemius or soleus from the calf. Again, watching that blood supply post-op is critical. It's a limb-threatening emergency if it fails.
Any alternatives to flaps for the leg?
Yes, for smaller areas, especially over bone or tendon, synthetic dermal templates are an option. You put the template down, maybe use MPWT over it to encourage blood vessel growth into it, and then put a skin graft on top later. Simpler than a flap sometimes.
Okay, one last really serious one. Necrotizing fasciitis? That sounds terrifying.
It is. It's a very rapidly spreading, life-threatening infection of the soft tissues down to the fascia, often caused by multiple types of bacteria working together.
What are the signs?
The classic sign is pain that seems way, way worse than the wound looks initially. It often starts after some break in the skin, even a small one, or maybe a pressure injury. In men affecting the perineal area, it's called Fournier's gangrene.
How does it progress?
Starts red, painful, swollen, maybe with fever. Then the swelling spreads, gets hard, skin might turn dusky red or purplish with blisters. Later, the skin can become fragile, black, indicating widespread tissue death. It spreads incredibly fast along those fascial planes. Patients get very sick, very quickly, septic shock, organ failure.
How do you diagnose and treat it?
Diagnosis can be tricky early on. Cultures might be negative. X-rays might show gas in the tissues sometimes. Often, the definitive diagnosis comes from surgical exploration, seeing the dead fascia, and biopsy.
And treatment.
It's a surgical emergency. Early, aggressive debridement is the cornerstone. Cut away all the dead tissue, relieve pressure, get samples for culture, start broad-spectrum antibiotics immediately, get infectious disease specialists involved.
Then bullfill surgery.
Usually, yes. Repeated debridements every day or so until all the non-viable tissue is gone. Wounds are left open, packed. Closure later might involve skin grafting, sometimes even amputation. Keeping the open wounds moist is important.
What's the long-term outlook?
Sadly, even survivors have an increased risk of dying prematurely from other infections later on. And there's a weird noted association with colon cancer.
Wow. Okay, let's bring this back to the patient scenario, Andre. The 22-year-old with paraplegia, sepsis from pressure ulcers. His situation sounds just awful and really highlights how lack of access can make things spiral.
Andre's case is heartbreaking, and it really shows the collision of medical, social, and personal factors. Young guy, devastating injury, loss of his friend, facing huge challenges.
And sepsis from ulcers he was dressing with newspaper.
Yeah, due to lack of funds and resources, it just underscores how social determinants, poverty, lack of support can have catastrophic health consequences. Plus, he's malnourished and smokes, both terrible for healing.
So, recommendations for him.
Immediate priority. Urgent surgical debridement of those infected ulcers. Absolutely need to check for underlying bone infection, osteomyelitis, get infectious disease involved. Once the infection is cooling down, maybe NPWT could help prepare the wounds.
What about long-term, preventing recurrence?
He desperately needs proper pressure redistribution, an integrated bed system, a suitable wheelchair cushion, and education on how to use them.
Could they do flap surgery to close the ulcers?
Technically, maybe, but his history of apparent noncompliance with even basic care raises huge red flags about whether a complex flap repair would survive long-term. You have to be realistic.
So focus on support.
Absolutely. Explore his social situation. Could a group home with peer support work? Get social services involved for medical benefits, supplies. PT and OT are vital for mobility assessment training. And you have to address the smoking, even starting with harm reduction. It's a multi-pronged approach.
His story really drives home how complex wound care is, way beyond just the dressing.
It truly does. It's the whole picture.
Okay, so wrapping up this deep dive on surgical wounds, let's quickly recap the main points. We looked at the normal healing phases: inflammatory, proliferative, remodeling, and the events within them.
Hemostasis, inflammation, repair, remodeling. Yep.
We stressed how vital preventing SSIs is, noting the different types and their impact.
And that many are preventable with good protocols.
We talked about why wounds might not heal those extrinsic and intrinsic factors and the need to find and fix the root cause.
Supporting the body's natural process by removing obstacles.
We discussed the reconstructive ladder starting simple, moving up complexity only as needed for tissue loss.
Primary closure, grafts, then flaps.
And we touched on specifics for different wounds, lacerations, burns, abdominal issues, pressure injuries, even necrotizing fasciitis.
It really is a broad field, requiring understanding of healing, complications, and using the right tools, surgical or non-surgical.
This has been incredibly informative. Really makes you appreciate the body's power to heal and the skill needed to help it, especially when things go wrong. So, on that note, here's a final thought for you, our listener. Considering the body's amazing innate ability to heal itself, what are the real implications when something as basic as access to clean dressings or medical advice becomes the main barrier preventing that natural process?
Yeah.
It definitely makes you think about how much circumstances can affect healing and raises big questions about fairness and access to care. Thanks for joining us for this deep dive.